welcome you all to this afternoon's ECHO meeting. And our topic of discussion this afternoon is childhood TB. With me in UTH Hub, my name is Dr. Myangana, and with me in the UTH Hub, I'm with Dr. Victoria Manzi, who is the HIV coordinator at Lusaka Provincial Health Office. With us, we also have a panel of experts who are going to be with us this afternoon. And these include Dr. Chalilwe Chungu, Ms. Winnie Mwanza, Dr. Richard Chimzinzi, Ms. Wangazulu, Dr. Kevin Zimba, and Dr. David Singini. So our experts, you are welcome, and you can just give us a signal in the inbox to let us know that you have joined. Without further ado, over to you, Dr. Manzi.
Thank you so much, Dr. Myangana, for that introduction. Supposed to share this.
Then share. Then top left corner. Top left.
Which one?
This one.
Okay. Thank you very much. As earlier introduced, my name is Victoria Manzi. I'm the Pediatric HIV Coordinator for Lusaka Provincial Health Office, and I'll take you through this presentation on childhood TB. As you may be aware, November and December have been declared childhood TB case finding months by the Ministry of Health. So in view of that, we have this presentation to remind ourselves of childhood TB. So the learning objectives for this presentation include highlighting the local and global burden of TB in children, who outline the diagnostic approach of childhood TB. We'll also look at the management of drug-susceptible TB in children, and we'll also look at prevention of TB in children.
Okay, so we'll start with our first 4 questions. And the question reads, choose the best answer. So we are choosing one out of the 4 options. So choose the best answer. And the options are A, childhood TB is not a major public health concern. B, childhood TB is difficult to diagnose all the time. C, childhood TB requires a bit more effort and a structured approach to make a diagnosis. D, none of the above. So we're launching the poll now. So we're expected to choose the best answer. So we can start polling in. Okay. So we pick one of the options that has been given. Which one do we think is the best answer? Is childhood TB not a major public health concern? Is it difficult to diagnose all the time? Does it require a bit more of a structured approach in making a diagnosis? Or is it none of the above? Okay, would like to see everybody participating in this poll. Only about 60% of the people on the poll have polled in. So give it a few more seconds before we close the poll. Okay. Okay, we're ending the poll. Okay, so Dr. Manzi, from what we can see here, the majority of the of the participants this afternoon think that childhood TB requires a bit more effort and a structured approach for us to make a diagnosis. And we had very few, that is about 9%, thinking that none of these options was the best. We had about 7% thinking childhood TB is difficult to diagnose all the time. And we had about 2% who think childhood TB is actually not a major public health concern. Please shed more light.
Thank you so much, dear network, for participating in the poll. And in this presentation, we'll be able to learn and discuss more about childhood TB. Okay, so tuberculosis is a communicable disease found in the top 10 causes of morbidity and mortality worldwide. Around 10 million people worldwide are infected with Mycobacterium tuberculosis, and 90% of TB cases are from 30 high-burden TB countries, of which Zambia is among those. Globally, only 6.4 million people were diagnosed and notified in 2021. From the previous slide, we learned that there are about 10 million infected, but only 6.4 were diagnosed. 1.6 million died from TB each year. COVID-19, as we know, has regressed the gains made in reducing global TB incidence. However, we must note that the incidence has increased by 3.5% per year. When we come to the local TB burden, a total of 60,000 people were estimated to have TB in Zambia in 2021. 7,900 people died from TB in 2021. In high TB burden countries such as Zambia, TB in children should account for at least 10 to 15% of all cases that are notified. So if you look at the estimates, we're at 60,000. However, we only notified 50,825, which is giving us a coverage of 84%, of which children were 3,890, representing 7%. So we still have a number of children that are being missed because overall we're supposed to have 10 to 15% cases as a childhood TB. So looking at the gains that have been made towards childhood TB notification and bacteriological confirmation, you can see where we are coming from. In 2018, the number of cases notified has been increasing. So you can see the trend in the blue line from 2,238 in 2018 to 3,908 in 2021. You can see also the bacteriological confirmation has increased more than 3 times actually, at 423 in 2019 to 1,352 in 2021. Then of note is that 29% increase in overall childhood TB notifications between 2020 and 2021 compared to 10% in the previous years. And we've had 53% increase in absolute numbers of bacteriological confirmation of confirmed cases in the 2 years, 2020 and 2021. We've seen an increase in proportion of bacteriological confirmation from 23% to 35% in 2021.
Okay, this leads us to our next poll question, and the poll question reads: a 2-year-old child with cough and fever for 2 weeks is brought to your clinic. Which of the following information is helpful in establishing a diagnosis of TB? So we have a 2-year-old child with cough and fever for 2 weeks who is brought to your clinic. Which of the following information is helpful in establishing a diagnosis of TB? A, static growth on under 5 card in the last 3 months and was treated for malnutrition 4 months ago. B, a child is breastfeeding from HIV-infected mother on heart for 3 years. C, the father died from TB 3 years ago. D, none of the above. So which information would be helpful for one to establish a diagnosis of TB in a 2-year-old who presents with cough and fever for 2 weeks? Is it A, static growth on under 5 cat in the last 3 months and was treated for malnutrition 4 months ago? B, a child is breastfeeding from an HIV-infected mother on ART for 3 years. C, the father died from TB 3 years ago. And D, none of the above. So I'll launch the poll. Okay, we can start polling in. Which of the following do we think is helpful information to diagnose TB in a 2-year-old who presents with fever and cough for 2 weeks? Okay, thank you for your participation. Those that have participated, for those of us that have not yet polled in, can we please do so? Do we think that a child having static growth on their under 5 card and having been treated for malnutrition is important information in the diagnosis of TB? Or is it a child who is breastfeeding from an HIV-infected mother who is on ART? Is it that the father died from TB 3 years ago? Or is it none of the above? Okay, only about 61% of the network has participated. Can we keep those answers coming? Okay, just a few more seconds before we end the poll. Okay, we are ending the poll now. Okay, so Dr. Manzi, the network feels that static growth on the under 5 card for the last 3 months and the child having been treated for malnutrition is important information. So that is about 71% of our network. And we have 20% thinking that the father dying of TB 3 years ago is important information. And about 11% feel that it's actually a child who is breastfeeding from an HIV-infected mother who is on ART. That is important information. And we had about 9% who thought none of this information is important.
Thank you so much, Dr. Myangana. From the results, the majority wins. However, I must say this was a tricky one because C is somehow a bit confusing. Exposure is important, but we look at the duration, and I'll speak to that, I think, in the next few slides. So how do we approach childhood TB in terms of making a diagnosis? I think in the first poll, we had a question asking about, there was one of the responses talking about TB requires a bit more effort, and that's what exactly it is. So childhood TB is like a puzzle where you have symptoms and signs, TB exposure, TB bacteriology, and chest X-ray. All these are vital in making a diagnosis. So when it comes to symptoms of chronic disease, we look at certain symptoms. We look for cough, fever, weight loss, or poor weight gain on the under 5 card. Night sweats, not very common in the younger children, but in the older ones, yes, and reduced playfulness. Normally children should play, but if the child is not playing, they are not active, could be suspicion, especially if accompanied by chronic cough, fever, and weight loss. When we look at risk of TB infection, so TB contact, so studies have shown that 5 to 10% of people exposed to TB will end up with TB infection in the next 2 years. So if someone has been exposed to TB within 2 years, That is very, very important. And in children, that history always stands out. There is usually exposure from an adult who could have suffered from TB. So 2 years, at least studies have shown that. Then TB bacteriology, here we want to talk about confirmation of TB. You've isolated the mycobacterium, or at least a component of the mycobacterium using GeneXpert, smear microscopy, mycobacterial culture, or urine lump. Okay, so these tests will show you that yes, there's TB, Mycobacterium tuberculosis confirmed. Abnormal chest X-ray, again, if you have access to X-ray, there are certain changes that we look at on X-ray that will point out to suspicion of TB, especially in younger children, and chest X-ray becomes very handy. So when you put the 4 together, you are able to make a diagnosis of childhood TB, okay? But sometimes one could be missing, and you have to make a probable TB diagnosis, okay? So presence of 3 or more of the following features: symptoms suggestive of TB, okay? The symptoms we've looked at: history of recent close TB contact, physical signs highly suggestive of TB. This is a baby who has not gained weight in the past 3-4 months and they have a cough, okay? Radiological changes suspicious of TB on chest X-ray, and a positive tuberculin skin test. So you can make a probable diagnosis if you have any 3 of these, okay? You don't have to have all of them, but you just need to have 3. So you can have symptoms suggestive of TB, a history of a close contact with TB, and a positive tuberculin test. And there you are, you have a probable diagnosis. Then you need to confirm. So a confirmed TB diagnosis is where you have a positive result on GeneXpert, smear microscopy, TB culture, or indeed a urine lump.
Okay, which brings us now to our third core question, and it reads, regarding TB diagnostic tools in children, A, MTB expert reef test is diagnostic when performed on sputum, stool, CSF, or lymph node aspirates. B, expert MTB reef test is diagnostic when performed on blood, sputum, stool, CSF, or lymph node aspirates. C, mycobacterial culture have no role in diagnosis of TB in children. D, chest X-ray findings are similar in young infants and adolescents. Okay, I'll read that again. Regarding TB diagnostic tools in children, A, expert MTB reef test is diagnostic when performed on sputum, stool, CSF, or lymph node aspirates. B, expert MTB reef test is diagnostic when performed on blood, sputum, stool, CSF, or lymph node aspirates. C, mycobacterial culture have no role in diagnosis of TB in children. And D, chest X-ray findings are similar in young infants and adolescents. So I'll launch that poll, then we can get to answer those questions. Which of the options do we think answers the question when it comes to diagnosis of TB in children? So which of the diagnostic tools is helpful in making a diagnosis of TB in children? Is it the expert MTB reef, which is diagnostic when performed on sputum, stool, CSF, or lymph node aspirates? Or is it B, the expert MTB reef test is diagnostic when performed on blood, sputum, stool, CSF, or lymph node aspirates? Or is it that the mycobacterial culture has no role in the diagnosis of TB in children? Or is it that the X-ray findings are going to be similar in young infants and in adolescents? Okay, only about 54% of the network has participated. So those of us that have not yet poured in, let's quickly pour in. Okay, just a few more seconds before we end the poll. Dr. Manzi, is this question so difficult? Because only about 65% now of the network has participated.
Maybe just a bit of uncertainty here and there, but yeah.
Okay, so we're ending the poll now. Okay. So from what has been poured in, about 79% picked option A. Okay, so they think that the expert MTB reef test is diagnostic when performed on stool, sputum, CSF, and lymph node aspirates, and we had about 18% who thought the expert MTB reef test is diagnostic when it is performed on blood, sputum, stool, CSF, or lymph node aspirates, and about 5% thought X-ray findings will be similar in young infants and in adolescents, and 3% feel there really is no role in the mycobacterial culture has no role in the diagnosis of TB in children.
Thank you very much, Dr. Myangana, and thank you very much, Dear Network, for participation. Option A, I think, is the best because when you compare it with option B, in Gene Expert MTB reef, we don't use blood as a specimen. So that's what makes B wrong. So that was a confusion which could have been there, making some people not so sure between A and B. So A is the best option. When you look at mycobacterial culture having no role in childhood TB, actually mycobacterial culture is a gold standard because that way you'll be able to confirm, even if there were a few mycobacterium, once you're exposed to culture, they will grow and multiply and you'll be able to confirm. Chest X-ray findings in infants have to be read differently compared to adults. There are certain organs that you'll find, such as a thymus, in younger children, which you will not find in adolescents. So when you're reading an X-ray in a child, the way you're going to interpret it is different compared to that of an adult. So they are not similar. Okay. So moving on, when we look at the specimens that we use for diagnosing childhood TB, sputum is a sample of choice. Remember, we are talking about a pulmonary infection. We have alternative methods to obtain the sputum because children usually will not follow instructions, the younger children, especially those below the age of 5. But there are 3-4-year-olds who follow instructions. However, we have those children who will not follow instructions, and alternative ways of collecting the specimen is doing a gastric lavage, a nasopharyngeal aspiration. We can do sputum induction, and thank God now we have stools as a sample for diagnosing TB. And I must say, stool compared to nasopharyngeal aspiration and sputum induction has got a better yield. Other specimens that we can use include urine, fine needle aspiration in case of TB lymphadenopathy or TB adenitis. You can do a tissue biopsy, CSF, acidic fluid, pleural fluid, and pericardial fluid, depending on the type of TB that you are suspecting. What diagnostic tools are available? We have the expert MTB reef, we have smear microscopy, we have culture, urine lamp, we have lamp, then we have chest X-ray, tuberculin skin test, and IGRA. I must say that tuberculin skin test will not confirm that someone has got TB or not, but it's a supportive diagnostic tool, whereby if someone has got symptoms and they get a positive tuberculin skin test, then you can definitely be sure and treat that person for TB. Just like chest X-ray will be more of a supportive, but will not point to Mycobacterium tuberculosis. Sorry. So when we come to treatment of TB, we have 5 aims, okay? When we are treating TB, we want to cure the patient. We want to prevent complications that may arise from being infected with TB. We want to prevent relapse. We want to prevent development of acquired resistance. Okay, we want to prevent transmission to others. So TB is curable, that we must know, and TB also has complications. So untreated TB may lead to more severe forms of TB, may lead to damage in the lungs, may lead to relapse, and also development of acquired resistance. So TB, resistance to TB drugs can be acquired, okay? So through someone not being treated or being treated partially, and also reduce or prevent transmission to others. So what are the steps that we need to take when initiating treatment? First of all, you need to determine the type and the severity of TB. So the type would depend on whether it's pulmonary, is it affecting the lymph nodes, okay? Is it affecting the joints or the spine? And then the severity, again, you have to look at, is it miliary TB or is it TB affecting the brain? Then we need to follow the recommended national guidelines. Then we need to determine the dosage according to the weight. So these are the regimen that we use. So all types of pulmonary TB and non-severe forms. We have 6 months of treatment, 2 months with 4 drugs, and 4 months with 2 drugs. So we have isoniazid, rifampicin, pyrazinamide, and ethambutol. Then for TB meningitis and other osteoarticular TB, pericardial TB, TB of the spine, and miliary TB, we treat for 12 months. So WHO has recommended a shorter duration where you have 4 months. So shorter regimen for non-severe TB, okay? So indications, children and adolescents aged between 3 months and 16 years, and it should be non-severe disease, okay? So this should also be bacteriological confirmed TB with gene expert, but excluding that confirmed by TB, by microscopy. So moving on, we'll talk about TB preventative therapy. So most of us have heard about TPT, which is TB preventative therapy. The indications, under 5 contact has been excluded. So here we are talking about children above the age of 1 year living with HIV, and these are given children more than 5 years, adolescents and adults who are contacts of TB patients. And also we consider contacts of patients with MDR TB, although the drugs that are used are different. What are some of the challenges when it comes to childhood TB? So we all know that TB in children remains underdiagnosed with gaps in detection, diagnosis, treatment, and also prevention. Most of us are not aware that there's TB prevention for children. Then in general, underreporting cases of childhood TB in Zambia and under usage of TPT in children. So in this discussion, what is it that we have learned? TB in children is a global and national burden. It's a public health problem. A diagnosis of TB in children is easy to make when you follow a structured approach. Management of children with drug-susceptible TB is similar to that of adults. Then place eligible children on TPT after screening of and ruling out active disease. Thank you so much.
Thank you so much, Dr. Manzi, for that elaborate presentation. So we'll open it up to the network, but before we do that, We'll do the repause just to see if learning has taken place. So we'll just share the pause again. Okay, so our first question is choose the best answer. Choose the best answer. So from what we have learned in this session with Dr. Manzi, do we feel the answers that we poured initially were the correct ones, or have we changed our minds? So choose the best answer from the 4 options. And the first option is childhood TB is not a major public health concern. B, childhood TB is difficult to diagnose all the time. C, childhood TB needs a bit more effort and a structured approach to make a diagnosis. And D, none of the above. So which of the following is the best answer? Is it A, childhood TB is not a major public health concern? B, childhood TB is difficult to diagnose all the time? C, childhood TB requires a bit more effort and a structured approach to make a diagnosis? And D, none of the above. Okay, I thought after this session with Dr. Manzi, it would just require a few seconds for all of us to pour in. Okay, we are going to end the pour now. Okay, Dr. Manzi, what is your comment?
Okay, thank you very much, and well done to the 92%. I know there could be 1 or 2 people. Sometimes that's the way you read the question and you end up getting it wrong. But we've all learned from the presentation that childhood TB requires just a bit more effort for you to make a diagnosis of childhood TB. We also learned that it's one of the major public health problems worldwide. Yeah, and it's not difficult to diagnose. It's easy. Yeah.
Okay, this will bring us to poll question 2. Okay. So in the second question, we have a 2-year-old who belongs. Okay, in the second question, we have a 2-year-old who presents to the facility with a 2-week history of cough and fever. Which of the following information is helpful? Which of the following information is helpful in establishing a diagnosis of TB? Is it A, static growth on the under 5 card in the last 3 months and was treated for malnutrition 4 months ago? Is it B, the child is breastfeeding from HIV-infected mother on heart for 3 years? Is it C, the father died from TB 3 years ago? And is it D, none of the above? So which of the following is useful information to help us make a diagnosis of TB in a 2-year-old who presents with fever and cough for 2 weeks? Is it A, static growth on the under 5 card in the last 3 months and was treated for malnutrition 4 months ago? Is it B, the child is breastfeeding from an HIV-infected mother? Is it C, the father died from TB 3 years ago? Or is it D, none of the above? Okay, we're ending the poll. Dr. Manzi, I think learning has taken place.
Yeah,
we can see 88% of the network actually feel that it's a static growth on the under 5 card.
Exactly, Dr. Myangana. So like we mentioned on the symptoms, one of the things that you have to look out is either weight loss or poor weight gain on the under 5 card. So if the weight is just flat on the under 5 card and the child was previously treated for malnutrition, could be a suspicion. Option B, I think there's no relation between being HIV infected and on ART for 3 years. This is a mother who's probably stable on ART, probably has been screened for TB, because at every visit for people living with HIV, we screen for TB and has been given TPT, so it should not be a threat to the baby. Option C, again, still a bit confusing. What we talk about and what studies have shown is those who have been exposed within 2 years and not 3 years. So yeah, that would have been the confusion.
Yes, and also in this case, the child is 2 years old.
Yeah.
Meaning the father dying was before the child was born.
Child was born.
Yes.
So that was a catch. Yeah.
Okay, and our final 4 questions regarding diagnostic tools in children. Regarding diagnostic tools in children, is it A, expert MTB test is diagnostic? Okay, network, kindly mute your mics. Those that are just joining us, please ensure that your mics are muted. Okay, we continue with the poll. So we need to choose the best option here. Is it A, expert MTB with test is diagnostic when performed on sputum, 2, CSF or lymph node aspirate. B, expert MTB with test is diagnostic when performed on blood, sputum, stool, CSF or lymph node aspirate. C, mycobacterial culture has no role in the diagnosis of TB in children. And D, chest X-ray findings are similar in young infants and adolescents. Okay, we're going to end the poll. Again, Dr. Manzi, I think learning has taken place. I'm proud to say 97% of the network feel that the MTB reef is diagnostic when it is performed on sputum, stool, CSF, and lymph node aspirates. We still have 3% that blood can be included to this list, but I think you already shed more light on this. And unless you have anything else to add?
No, I think Dr. Myangana, you are very right. So well done to the network. Learning has taken place. To the 3% that are still thinking blood can still be a specimen on the ordinary expert MTB reef machine, you will not be able to do tests with blood. But on other forms of expert, like expert ultra, you'll be able to run that sample. So well done to the network, and thank you so much. I'm glad no one thinks mycobacterial culture has no role in diagnosis of TB. So thank you so much.
Okay, network, at this point, we'll open it up for questions. Those that have questions, you can just either type in the chat or you can raise your hand and ask any questions, anything that we did not understand in the presentation, or anything you were looking forward to learning but was not covered in the presentation. We have our experts on the call. We have Dr. Kevin Zimba. We have Dr. Rehab Chimzinzi. We have Madam Winnie Mwanza. We have Madam Wangazulu. Okay. So there's a hand from GKC. So GKC, you can unmute and ask your question. GKC. Okay. GKC, okay, GKC seems not to be ready. There are some questions in the chat. Okay. So Dr. Manzi, you can just take note of these questions. So the first question is, can 3HP be given to children under the age of 5 years?
Hello, good afternoon.
Yes, good afternoon.
Sorry, you were not enabling me to talk. You could not, I did unmute, but you were not allowing me to talk.
Oh,
This
sorry
is
about
GKC.
that.
Yeah, please.
Yes.
This is Gabriel from Northwestern Province.
Okay, you can go ahead, Gabriel.
Sure. During the presentation, you just mentioned something that WHO has recommended, the short regimen for the bacteriologically confirmed TB by gene expert. We as a country already started implementing that, or we shall have to wait for new guidelines? That is all I wanted, because the questions have been coming after, but we haven't gotten a clear-cut the instruction about that. Thank you.
Okay. All right, thank you for that. Okay, so we'll be taking 3 questions at a time. So we'll also take the question from Joseph Piri from the chat, which says, what role has urine lamp in diagnosis of children? Okay, so the first question on 3HP, Dr. Zimba, you can help us to answer that question. Then the question on urine lamp, Dr. Singini can help us answer that. And the question on the WHO recommendations, Dr. Zimba can answer that for us as well. Dr. Zimba, are you on the call?
I can take the one on PHP.
Okay, as we are waiting for Dr. Zimba, Dr. Manzi can go ahead and answer the question on the 3HP.
Okay, thank you very much. So for 3HP is given to adolescents and adults who weigh above 50 kg. So it's not indicated in children less than five years. Okay, then for the question on use of urine lamp. Okay, use of urine lamp in children. So urine lamp has been used in children, and its application is that once you get a positive urine lamp, that's confirmatory of TB in children. I know in the adult population, we've used it much more or the positivity is much more in those bedridden adults, like those who are very, very sick. But for children, we have used it, and a positive result with symptoms confirms that the child has got Mycobacterium tuberculosis. And we have a case, I think later on we'll discuss a case that was diagnosed using urine lamp.
Okay, thank you for that. Okay, I think that is all the questions that have been answered.
One for 10 minutes. It is a complicated Dr. Zimba for 3 months. We are waiting for you.
Okay, Dr. Zimba, are you on the call now? Okay, any of our experts on the call, maybe you can help us. There was a question to say the short regimen for children, the one that has been recommended by WHO regarding children with uncomplicated TB, have we as a country rolled it out, and are we implementing?
Hello, good afternoon. Dr. Ziambo here.
Yes, Dr. Ziambo.
Great presentation, Dr. Manzi, and great facilitation, Dr. Myangana. Nice to see you again.
Thank you.
So regarding the short regimen, the Minister of Health hasn't yet adopted it, despite it having been recommended in certain sections by WHO, and because there's still a few more things that we need to put in place before we can actually implement it. So we have not yet adopted it on that one. And I just wanted to just make a few additions to the response in terms of use of urine alarm in children. So according to our guidelines, it's restricted to children HIV positive and children who are malnutrition and those that are less than 5 years old those that are living with HIV, and then those that are less than 5 years old and have malnutrition. So that is according to latest guidelines. So if we have the new TB guidelines, they are out. And if you don't have a copy, we will share the copy with everyone. And so please share it wide so that we know how to treat children with tuberculosis. Thank you so much. Great interaction. Looking forward. Thanks.
Thank you
Sorry,
so much.
Dr. Manzi and Dr. Zambia, apologies. I was unable to mute myself before.
Sorry about that, Dr. Zimba.
All right, okay. So I'm not contradicting. So Zambia has opted to go the operational research route on the 4 months dispensation. It's there in our guidelines, but we don't want to roll it out completely to everybody. So we'll start an operational research model where we'll start with the big tertiary hospitals where at least there is a pediatrician who can follow up these children for a year so that we get to see what the outcome would be. We are using this model because of a few lessons that we learned from the DRTB shorter regimen. We found anecdotally that there are some patients that have some issues with the shorter regimen, so we want to go the cautious route. I know the SHINE study was quite elaborate and done in an almost practical research, a practical model, so that we could draw it out easily when coming to implement. But because of lessons from the other study, we're going cautiously. And I think that's just an addition to what Dr. Zambo was going to say. We're going at it cautiously to avoid complications. Thank you, and great presentation.
Thank you, Dr. Zimba. Okay, so there was a question regarding urine lamp.
Hi.
Yes,
Hi.
please.
Yeah, Dr. Lungu just want to also add to what Dr. Zimba has ably explained as well.
Yeah.
Thank you. You can go ahead and welcome.
Yeah, thank you, Chair. And let me just commend the presenter for an excellent work done. And just in addition to the 2 previous speakers, Dr. Ziambo and Dr. Zimba, indeed, we have adopted the use of the shorter regimen. If you look at it in the latest guidelines, the 4 months regimen is there, but with certain conditions. As Dr. Zimba mentioned, this will be implemented under a very cautious approach. And one of the things what we want to make sure is that we want to optimize the good results. So we will start with the tertiary level hospitals and scale up to the other grassroots based on the outcome. We've been slow to start. So Dr. Zimba, I think we need to put our heads together as quickly as possible, develop an implementation plan of the shorter regimen. So indeed, it's in our guidelines, and as soon you receive more extensive guidance on how we shall roll out the shorter regimen. Thank you.
Thank you, Dr. Lungu. Before you go, Dr. Lungu, would like to tap into you. So there's a question in the chat which says, please shed more light on TPT in context of DRTB cases, especially if the index case is confirmed MDR-TB. So I'm kindly asking if you can take that one as well.
Okay. Yeah, so thank you. But before I go to the question you just asked, may I also just come in on the list of 3HP? So the minimum dose for 3HP is 30 kg. And usually for now, we are targeting those who are aged 15 years and above. But should there be an 11-year-old who is weighing above 30 kg, that individual qualifies. So there are 2 cutoff points, age 14, as well as the weight of minimum, each being 30 kg. I hope that that has been understood. Then coming to the questions for TPT in context of DRTB patients, you will see that our guidance here has not been that clear-cut for the simple reason that it is highly dependent on the resistance profile of the index patient. So in an event, this individual is purely MDR resistant to isoniazid as well as rifampicin. So the drug of choice to be used is levofloxacin. So levofloxacin can be used as an individual drug or in combination with ethambutol. So where it's feasible, combine the two drugs, and the treatment duration for TPT is not less than 6 months. But the preferred one is that you can actually go up to 9 months. So you can minimum remain 6 months, but optimally go up to 9 months. So those are the drugs that are being utilized. But more important, in an event you have a DRTB child who's been exposed, a child who's been exposed to a DRTB patient, you need to work hand in hand with the clinical expert committee, either at national level or even at provincial level, so that they guide. So you need to pay particular attention to the resistance profile of the index patient. It is of paramount importance so that you tailor-make the TPT to that particular child. I've seen that
level and this is the dose or frequency.
Yeah, so the frequency for level, I've forgotten the dosage per kg. So it has to be per kg. It should be about 10 kg, if not 15 milligrams per kg body weight. And it has to be dosed, it has to be given daily. So the dose is 15 milligrams per kg. I may need to double check the dosage. And it has to be given daily for 6 to 9 months. I hope that's correct. That has been taken up. Over, and thanks.
Thank you so much, Dr. Lungu. I hope the questions have been answered for those that asked. So for those questions that have not yet been addressed in the chat, we will assign our experts to answer those questions within the chat box. Due to time, we cannot take any more questions at this point. We'll move on to look at the cases that have been prepared for us this afternoon, and we'll discuss those now. I hope Chilanga is ready. Chimunya, are you ready?
Afternoon, Doc. Yes, we're ready.
Okay. So can we share from our end, or would you like to share?
No, you share from your end.
Okay.
We have small gadgets here.
All right.
Oh, let me check.
Okay.
Stop sharing this one, don't you?
Okay, Chimunya, over to you.
Okay, thank you so much, Doc. So good afternoon, network. So this is a case presentation that we're going to share from Chilanga district, Chilanga Urban Health Center. So we have a 4-year-old with who's on second line and started ART in November 2018. She was tested positive for HIV at the age of 6 weeks. but we only managed to receive these results at 12 weeks of age. She has a history of defaulting ART for 1 year, 3 months with poor adherence. So after interrupting in care, she presented to the facility in February 2021 with a 2 month history of a cough, fever, swelling of the abdomen and the face. So malnutrition and TB were suspected at that time. She had no history of TB contact. So she was referred to UTH, but the mother refused to go to UTH. So we did a urine lab at the facility, and the child was managed from a local health facility. So we really wanted this child to be admitted, and so we referred the child to our hospice in Chilanga. Urine lab results came out positive. And so the drug history for this child is that she's been on AZT3TC lopinavir, ABC3TC. The first regimen was AZT3TC nevirapine, and then ABC3TC lopinavir. She has a family history of being the 4th born in the family. She lost her immediate young sibling at the age of 1 year, 3 months. The other 2 children are HIV negative. She lives with the grandmother and the mother, since the mother and the father are separated. So the mother joined the mother, and they're living together with the mother. So the immunization history and maternal history for this child is that the under 5 card was not available at the moment. At the time we were seeing the child, the mother tested positive for HIV antenatally, but only started ART postnatally. Currently, the mother is suppressed and is on first-line ART. Okay, next slide. So we go to the examination. So general condition, the child at that time was ill-looking, puffy, swollen abdomen with bilateral pitting edema, had crepitation bilaterally, CVS S1, S2 head, and they were normal. The abdomen, it was distended but non-tender, and there was no organomegaly. Vitals, oxygen levels were at 94%, and respiration 30 per minute. Temperature was 37.8. The pulse was 101. The weight was 5.7 kgs with standard deviation at -4. So this child was not doing very well. So we look at the treatment and investigation starting from 2018. We have there the HB was at a sorry, sent it to CD4 was at 650 cells per minute, 3 lopinavir. And then 2021, chest X-ray was not done. We don't have X-ray machines, so only urine lab was done. It was positive, and then the child was still on the same regimen and was started on ATT. That is in 2021. And then, we had very low results again, and copies were 1,613 per mil. The child continued EAC as the viral load was too high. And then somewhere in March this year, copies went up to 13,192. So the child continued EAC, but after that in June, we decided to put this child on AZT3TC DTG. Next slide. Our questions now are that is contact trace, there's noise in the background, okay? So our question is that, so these are our 3 questions. Is contact tracing necessary in a child who tests positive for TB using urine lamp? 2, should preventive therapy be provided to other household members when someone tests positive using urine lamp? 3, how can we ensure that this child living with HIV with unsuppressed viral load does not suffer from TB again? So these are our questions. Thank you so much.
Okay, thank you so much, Nchimunya. For those that are joining us, this is a case that Chilanga has shared with us. So it's a case of a 4-year-old who's RVDR on second line and has also a history of interruption in treatment for 1 year, 3 months prior to presentation and poor adherence. So this child presents with a 2 months history of cough, fever, and general body swelling. There is no history of TB contact. So TB lamp was done on the child and the results came out positive. So on examination, the child had anasaka and crepitations bilaterally. So those are the questions that Chilanga is asking us, and they would like us to discuss this case with them. So the first question is contact tracing necessary in a child who tests positive for TB using urine lamp? So we'll open it up to the network. We'll open it up to the network. We'll just get just 2 contributions on each question from the network. Then our experts can come in for us to discuss the case. So do we feel that contact tracing is necessary for a child who tests positive using urine lamp? Okay. Should preventative therapy be provided to other household members when someone tests positive using urine lamp? Any takers from the network? You can raise your hand and we can give you a chance to speak. Okay, Kajima, you can go ahead and speak.
Okay. Good afternoon, network.
Yes, good afternoon, Kajima.
So on the contributing on question number 2, I think, contributing on question number 2, I think it should be given since there was a history of this child coughing for more than 2 months. We can put him on. Thank you. And over.
Okay, thank you for that contribution.
There's a question in the chat.
Okay, there's a question in the chat which says, why is the child not on PDTG regimen? Okay, I think the child is on PDTG.
So the child will switch to second line, which is AZT3TC DTG. Yes, that's the current regimen.
Is there a hand?
Okay. So there's a hand from ADCH. You can go ahead.
Okay, good afternoon, network.
Yes, good afternoon.
Thank you. I'll go with question 1, which is saying, is contact tracing necessary in a child who tests positive for TB using urine lamp? The answer for me will be yes, because this is a bacteriologically confirmed case when the urine lamp comes out positive. So it's necessary for us to allocate the source of infection where this child got the TB from. Then the second one, is it necessary to put those that in contact on prophylaxis for somebody who present with a urine lamp which is positive? I'll agree yes or no, depending on symptom. If this, because what I understand for urine lung, you marry it to say it's a pulmonary tuberculosis if the patient presents with the symptoms of respiratory system. If it's extrapulmonary, if the patient probably present with ascites, you may marry it to be an extra. But if the patient comes with a urine positive with a respiratory symptom, automatically those that are in contact, especially the under 5, those whose who are HIV positive, who are immunocompromised, they are supposed to be put on the prophylaxis. Then the third one, how can we ensure that the child living with HIV with unsuppressed viral load, definitely this needs to be initiated on TPT if they have never received the prophylaxis in the last 3 years. I submit.
Oh, sorry about that network. Okay, so due to time, the questions that are in the chat will be addressed in the chat. Now we're going to throw it to our experts to help us discuss this case. So question 1 will be taken up by Madam Wangazulu. Question 2 will be taken up by Dr. Singini, and question 3 will be taken up by Dr. Zimba. So over to you, Wanga. You can help us discuss question 1.
Thank you very much and good afternoon.
Good afternoon,
So,
thank you.
Question 1 is looking at whether contact tracing is necessary. So from the expert perspective, contact tracing is necessary. We are looking at this child having bacteriologically confirmed tuberculosis, but then with a child, we do contact tracing to find cases where the child would have gotten the infection, which is called reverse contact tracing. So it is very necessary that a child whose lung test is positive is contact tracing is done to the family. My submission.
Thank you, Wanga. We can move on to question 2. Dr. Singini.
Hi, Dr. Mnyangana. Very, very good question indeed. So regarding TPT in contacts to people diagnosed via LAM, yes, rather TPT can be given in those individuals. But however, we also need to remember the eligibility for TPT. It should apply in this case as well. So if there's an individual in a particular household that tested positive for TB using urine LAM, is that household having a child that is under 0 to 4 years old? If yes, TPT is recommended. If there are people living with HIV with no previous history of taking TPT, TPT should be considered in those individuals. And also there are those high-risk populations that have suppressed immune system and have been in contact with these individuals. TPT should be offered to those individuals. So I must also emphasize that particularly in this patient that we're discussing, this is a patient who was having respiratory symptoms and also coupled with the positive urine LAM test. we could use our clinical knowledge to conclude that this was a case of pulmonary TB. So this patient was actually highly infectious. But just to emphasize to the network that by all means, we should try to utilize molecular tests such as ExPERT to confirm a diagnosis of TB in all the patients that we have, for the obvious reasons that we could be dealing with a case of drug-resistant TB. And the TPT option, like was discussed earlier, might not be the best. And as such, also the patient that is on treatment might be receiving drug-sensitive TB, and yet they have drug-resistant TB. I thought I should add that to the discussion. Thanks, and over.
Thank you, Dr. Singini. And we'll now give a chance to Dr. Zimba to tackle the third question, after which we'll call upon Dr. Rehab Chimzizi, who is also one of our experts this afternoon, to just wrap it up. Over to you, Dr. Zimba. Okay, Dr. Chimzizi, I think you can go ahead and just comment on the questions that are before us.
Yeah, I think I just wanted to comment on the overall presentation, to say that a very good session. Just wanted to add that while we have a wide range of diagnostic tests, including even the chest X-ray, I think the most important thing also not to forget is about clinical evaluation, because some of the decision will be made clinically. So I think the clinical evaluation has to be also be part of the approach to use, even to make sure that we make a diagnosis of TB in children. Indeed, definitely the most critical thing is the issue of using sensitive tests, because we even have an easier way of making sure that, particularly in children 0 to 4, stool testing is very, very critical. I just wanted to add that we should not forget the clinical evaluation while we think about all these tests available to us. And the last one, I think Dr. Lungu wanted to speak on one issue. Over to you, Dr. Lungu.
Yeah, thank you very much. Indeed, once again, Dr. Manzi and cohort, you've done a fantastic job. I commend you for your clarity in your presentation. But I just wish to just clarify on one or two things. Number one is on the TPT. Who qualifies for TPT? Should we factor in the viral load? Certainly, or CD4. So just want to share with everyone that for TPT eligibility, viral load status is not a factor. Neither is the level of CD4. So what is important is one having either exposure to TB or one being a child who's living with HIV. So the CD4 or viral load should not be factored in as part of the eligibility criteria for TPT. What it just should be considered is a child free of TB symptoms, is a child free of TB signs, and thirdly, have they ever received TPT, and when did they receive the TPT? So those are the three parameters to consider, and not viral load and CD4 count. So I hope this is very clear. So just to respond and to be very categorical, any child who is living with HIV, be it virally suppressed or not, they qualify for TPT. And then lastly, I just wanted to just augment what the presenters and others have said about the role of the chest X-ray. So the chest X-ray plays two functions in TB diagnosis. One, it can be used as a TB screening tool. Secondly, as a TB diagnostic tool. So the point just to take is that a chest X-ray is a TB diagnostic tool. So diagnostic when there are features that are pathognomic of TB. So what I'm simply saying that there are certain unique features that are unique for TB. I'll give an example. In children, one may have bilateral lymphadenopathy. You hardly see cavitations in children or effusions. At times, effusions do occur, but they are quite a rare occurrence. So when you see certain features, such as a miliary picture, features such as bilateral lymphadenopathy, these two and many other features are pathognomic of TB. So meaning when you see these features, there are symptoms indicative of TB as well as some risk factors for TB, then that can be used as a ground for starting TB treatment. But not to negate what others have said and what the program continues to emphasize on, bacteriological confirmation. So any child that we are starting on TB treatment based on clinical ground or clinical features, we should make every effort to collect stool, or at least gastric lavage, now also the nasopharyngeal aspirate. So any of these three must actually be done. If they come out negative, you still have the clinical grounds to start that patient on treatment, and they need to be clearly stated why we are starting a child on clinical grounds. So the history has to be well documented. The physical findings has to be well documented. Be it the chest X-ray findings must be equally stated, and why you are arriving at that working diagnosis of active TB in that particular patient. So again, job well done, colleagues. Let's continue pushing and saving the precious lives, which are the future of this country. So with that, I commend you once again and many thanks. Bye-bye.
Thank you, Dr. Lungu. Okay, so just to wrap up our questions this afternoon, I don't know if Dr. Zimba is on the call now to just answer the third question for us.
Hi, so I thought Dr. Lungu has tackled that question as well, the third question. So basically we're saying to ensure that our children who are living with HIV, virally suppressed or unsuppressed, don't suffer from TB again, they should receive TPT. I think currently our guidelines are saying if somebody has received TPT more than 3 years ago, they're eligible to receive a next dose of TPT. There may be some changes in the near future also, but currently that's what our guidelines say. So I think TPT is a key intervention in preventing TB. And I think even when we look at our statistics themselves, TB in the PLHIV did reduce to around 34, 36% somewhere, 34, 36% somewhere there. Just because of TPT, we've made that big drastic drop from it being 60% of our TB cases were HIV related about 2014, 2015, somewhere there. Currently, we've gone to about 84%. I think that's my comment. TPT is a key intervention here. Thanks.
Okay, thank you, Dr. Zimba. So we have a hand from Dr. Singini and a hand from Dr. Ziambo. So you can go ahead and give your comments in that order, Dr. Singini and then Dr. Ziambo.
Thanks, Dr. Myanga and the team. Also, thanks to the NTP manager and his team. Sorry, I wanted to speak to question 3. Dr. Zimba has ably responded to the TPT component, but I think also just to emphasize the need to optimize the ART in this patient so that we can get this person to be suppressed, and we know the obvious advantages related to that. In another non-clinical perspective, this is a child that would need to optimize the nutrition so that they can strengthen the immune system in a non-pharmacological way. And then, of course, we need to implement infection prevention measures wherever this child is living. The basic things that we all know, improving ventilation, if they're exposed, if they are in an environment where there's 1 or 2 people that might have TB, we need to implement these infection prevention measures so that we reduce the transmission. This is just as an ad hoc to what was shared by Dr. Zimba. Thanks, and over.
Thank you, Dr. Singini. Dr. Ziambo?
Yeah, thank you so much. I think I was going to respond to question 3, but I think they've ably answered it. But ongoing, we, in our day-to-day care, we need to always be screening for TB, and that is part of prevention. Always screen for TB. Ask those questions that will screen for TB. Any members who have TB, do they have any symptoms of TB? That is also an important way of early detection and being able to put them quickly on treatment should they have any kind of symptoms that they may develop. This has been a very exciting presentation and discussion today. We were joined by so many people. We reached almost 470 connections. So we've agreed that we're going to have this session again on Thursday, where we'll dig down deeply into the TB guidelines. So we will have this session. So we're inviting all the health care workers one more time to join us on Thursday this week, and the TB team will be able to put up an overview of the TB guidelines so that we are quite aware. So this will be on Thursday at 12 hours to 13 hours, so we can take some time off and be able to just participate in this particular session that will be done on Thursday. I think that being said, thank you very much, everybody, and thank you. Thank you, Chair. Bye.
Thank you, Dr. Ziambo. And just to add on to what Dr. Ziambo has said, initially we were to have 2 cases this afternoon, but seeing how the network was participating, we were not able to present the other case. So this case will be moved forward to Thursday. So that is the case that is going to be discussed. So please make a date. We had a hand from Musa Namakau. So Musa, you can go ahead and contribute. If it's a question, you can go ahead and ask. If it's a contribution, you can go ahead as we prepare to wrap up this afternoon's session.
I think she's failing to unmute herself or something. Let me go ahead and say many thanks to you, Dr. Ziambo. I think we called on you short. This is Kevin. Many thanks. We called on you at short notice to allow us to have this echo session. And I think I was happy to see the over 400 plus participants. Many thanks to NTP managers for accepting this. And I would like to encourage the community, the healthcare workers out there. This is Childhood TB month. I know we'll go ahead into December. Let's go out and find more TB cases. We did it last year. We had more notifications of childhood TB in the month of November last year. Let's repeat what we did last year. And many thanks, Dr. Manzi and team, for those cases. And looking forward to the Thursday presentation. We'll see who and take it up and prepare for the slides. Thanks.
Thank you, Dr. Zimba. Although I was reserving you to give the closing remarks. Okay, so if there are no...
Sorry, Dr. Nyangana, the NTP manager is on the call. He will give the closing remarks.
Okay, thank you for that.
Okay.
Okay, I think Musa seems to be talking, but we can't get you.
Good afternoon, everyone.
Yes, good afternoon. You can go ahead.
Yeah, I wanted to ask on the answer which came from Dr. Zimba on question 3. Is it okay to start if the viral load is so high, is it okay to start the baby on TB treatment? That's my question. Thank you.
Dr. Zimba,
I can respond, yes. So according to our guidelines and the latest information that we know, starting TB treatment is a priority. So we'll start this patient on TB treatment regardless of the viral load, whether be it high or low, they need to start TB treatment. And then 2 to 3 weeks later, they're eligible to start ART treatment. So yes, we should start TB treatment. And then once the patient has stabilized, we start them on ART treatment. The reason we're doing that is that these TB drugs and ART drugs have some correlated side effects. So it allows us time to know which side effects would have developed if we start the ART after 2 weeks. Thanks.
Thank you, Dr. Zimba. Any pressing questions? We have 5 more minutes. Any other pressing questions? Okay, so there's someone who typed in the chat, Gilbert Mufungwe. You said you had a question and you had raised your hand. So you can go ahead and ask your question, Gilbert. Is Gilbert still on the call? Okay, Peter Singongo, you can go ahead and ask a question. Okay, Peter, you can unmute yourself and ask your question. Peter Singogo from Police Clinic.
Thank you. Mine is just an observation that what I would say is that we've had about 2 clients, those that we did gene experts, it came out negative, but when we proceeded with LAM, actually it was able to help us and the results came out positive. And we had to put our patients on treatment, and then they were able to improve, and then we were able actually to win them off when they finally finished the treatment. That's just a contribution that I had for the network. Thank you.
Thank you so much for that testimony, Peter. That goes to show that really as healthcare workers, these sessions are helping and we are doing something about it. Thank you so much. Okay, so with 2 minutes left, we'll ask Dr. Lungu, if he's still on the call, just to wrap everything up for us and give the closing remarks.
Yeah, thank you very much to our 2 presenters as well as the moderator and equally the panel. I would also just wish to thank all the listeners who have actively participated in today's session. And the colleagues that Dr. Zimba mentioned. With that, I would like just to thank everyone once again and see you soon. Bye.
Bye.
Bye-bye.
Bye.